Welcome to this special deep dive. Today, our mission is to act as your audio companion as we walk through the latest update of the Ebola disease. The medical community has officially made a massive terminology shift. They have literally crossed out the name Ebola hemorrhagic fever and replaced it with Ebola virus disease.
And that name change represents a really profound shift in medical understanding.
Uh,
When you hear hemorrhagic, you naturally assume the primary threat is blood loss.
Right, you think of like bleeding out.
Exactly. But major bleeding, that horrifying internal and external hemorrhage we've all been conditioned to expect, is actually quite rare in most patients.
Wait, really? It's rare.
Yeah, really is. When it does happen, it usually only occurs right at the very end in the terminal shock phase. It is a late-stage complication. It's not the main event.
So, if it's not massive blood loss killing the patient, what is it? Because the current clinical paradigm on this slide labels the true threat as massive fluid loss.
Yeah, the primary driver of severe illness and mortality is catastrophic dehydration.
Wow.
The virus attacks the gastrointestinal tract with such ferocity that a patient can experience, well, up to 10 liters of watery diarrhea per day.
10 liters. Okay, let's just give that some perspective for a second.
It's hard to even picture.
Right. Imagine emptying 5 large 2-liter soda bottles of fluid every single day. That is the volume of water being violently drained from a patient's body.
Which is just devastating.
The human body only holds about 5 liters of blood to begin with. Losing 10 liters of fluid a day is a volume collapse that is almost hard to comprehend.
Absolutely.
So it's not a hemorrhagic movie monster bleeding you out. It's extreme, rapid, catastrophic dehydration leading to multi-organ failure.
Right. And that volume collapse changes our entire approach to saving a life. We'll get into those specific clinical interventions shortly. But before a patient ever reaches a triage tent, we have to trace exactly how this virus spreads in the real world.
Let's do it.
The guidelines map out 3 distinct stages of transmission, and the first stage starts deep in the wild. We call it the enzootic reservoir.
And the reservoir is bats, right? Like, that's the origin.
Specifically fruit bats, yeah. And what's fascinating here is that the virus is maintained within these bat populations in the wild without actually causing severe disease in the bats themselves.
Oh, wow. So they're just fine.
Pretty much. They carry it, they shed it, but they don't die from it. They are the perfect natural host.
But this virus doesn't just, spontaneously generate in humans. There has to be a bridge from those bats to us. How exactly is that jump happening? Because the guidelines call this second stage zoonotic spillover.
Yeah, that spillover happens through close physical contact with the blood or bodily fluids of infected animals. And it's not just bats, by the way.
Oh, boy.
Yeah, the virus can infect chimpanzees, gorillas, and even forest antelope. Often, local populations will find these animals dead in the rainforest, or they might be hunted and handled as bushmeat.
Right, just normal, everyday survival activities.
Exactly. And a tiny cut on a hunter's hand while preparing that meat is literally all it takes for the virus to cross the species barrier.
Man, that initial spillover event is just the spark. But the third stage, that's the fire, human-to-human spread.
And this is where things get critical.
Right, and the crucial detail here for anyone trying to stop an outbreak is understanding the actual mechanics of that spread. It is not airborne.
No, they're not.
You can't catch it just by breathing the same air in a room. It requires direct physical contact with infectious body fluids, so blood, feces, vomit through broken skin, or mucous membranes like your eyes or mouth.
Which brings us to the 2 most high-risk contexts for this spread. First, you have unprotected healthcare provision.
That's just terrifying to think about.
It is. You have doctors, nurses, and family members desperately trying to care for the sick without the right personal protective equipment.
Right.
And second, traditional burial ceremonies that involve direct, hands-on washing and preparation of the deceased.
Which is just deeply tragic. It means this virus specifically exploits our most fundamental human instincts.
Exactly.
Like the drive to care for our sick loved ones and the cultural need to physically honor our dead. And according to the clinical data here, when a person dies of Ebola disease, their viral load is at its absolute peak.
Yeah, it's at the maximum level.
So the body basically becomes an extreme biohazard.
It is a devastating reality for the communities affected. So, if we understand that direct contact is the spark, imagine the pressure on the medical staff when someone actually walks through the clinic doors.
I can't even imagine.
Right. How do you even begin to safely triage that?
Well, the guidelines present triage as a literal life or death logic tree. You have three pathways. Let's look at the high-risk pathway first. This is someone who has had direct physical contact with a symptomatic patient, a dead body, or perhaps a healthcare worker who suffered a needle stick or processed blood without proper PPE.
Yeah, that's a worst case scenario.
The action here is immediate, uncompromising isolation. Single room, private bathroom. You notify health departments instantly, and you strictly limit phlebotomy.
Meaning you do not draw their blood unless it is absolutely essential for survival.
Because of the needles.
Exactly. Every single needle used is a massive exposure risk to the medical staff. You have to minimize sharps.
Okay, now contrast that with the middle pathway. Asymptomatic identifiable risk. This is the one that really gets me, actually.
Yeah, this one is tough.
This is someone who knows they were exposed, maybe they helped carry a sick neighbor, but they currently feel completely fine. They have no symptoms.
Right.
The guidelines dictate monitoring them closely for 21 days, but the protocol emphatically states do not quarantine them with sick patients, and diagnostic testing is not yet warranted.
Those rules are written in the hard lessons of past outbreaks, for sure.
I bet.
I mean, think about the psychological toll here. Imagine sitting in a room, perfectly healthy today, knowing you might have been exposed, and just waiting for a fever to spike over the next 3 weeks.
Just agonizing.
And if a clinician were to put that asymptomatic person into a holding ward with people who definitely have Ebola disease, they're essentially ensuring the person gets infected if they weren't already.
Which is a nightmare.
Totally. Furthermore, testing them while they have no symptoms is a waste of precious resources because the virus hasn't replicated enough in the bloodstream to even show up on the RT-PCR test. You just have to wait for the fever.
And then the final triage pathway is no identifiable risk. This is someone who traveled to an endemic area but had absolutely no known direct contact with a sick person or animal.
Right, just a traveler.
For them, the priority is evaluating for other prevalent diseases. I mean, you don't want to throw someone who just has a bad case of malaria into an Ebola isolation ward.
Absolutely not, which perfectly transitions us into the trajectory of the illness itself. If a patient is infected, what actually happens to their body over the next 12 days?
The clinical severity curve on slide 5 provides a really clear roadmap for this.
Yeah, it breaks it down well. Days 1 through 4 are the early febrile phase. The viral load is just starting to aggressively climb.
And the key markers clinicians look for early on are leukopenia, which is a severe drop in infection-fighting white blood cells, and elevated AST and ALT liver enzymes, which tells the doctors the liver is already starting to take damage.
Right. But the critical inflection point on this trajectory curve happens right around day 8. This is the platelet nadir.
The lowest possible point for blood platelets. The data shows them dropping to between 50,000 and 100,000 per microliter. That's scary low.
It is. That sudden drop is the crossroads of the disease. It marks the transition from the gastrointestinal phase, that period of severe 10-liter-a-day diarrhea we talked about, into either the shock phase or the recovery phase.
Okay, so it's make or break.
Exactly. Day 8 is when the patient's immune system either begins to turn the tide and clear the virus, or their organs start to completely shut down from the hypovolemic shock of losing all that fluid.
To really understand the systemic chaos happened beneath the surface leading up to day 8, the guidelines detail this cascading nightmare. It starts with an abrupt presenting syndrome, right? Like a sudden high fever, chills, profound fatigue, and just a splitting headache.
Yeah, it hits them like a truck.
And by day 5 to 7, patients often develop a diffuse non-pruritic, which means not itchy maculopapular rash that can actually peel off. And the guidelines specifically note this rash is much easier to see in light-skinned patients.
That is a vital clinical pearl right there. Diagnostic observation has to be tailored to who the patient actually is, but the visible symptoms are really just the tip of the iceberg. We have to look at the massive GI and volume collapse.
Right. Let's go back to those 5 large soda bottles of fluid being lost every single day. The body is being rapidly drained of essential electrolytes, so potassium, magnesium, and sodium.
It's completely flushed out.
I like to think of electrolytes as like the electrical wiring for the heart and organs. If you drain them, the grid just fails.
That's a great way to put it. And the immediate downstream effect of that grid failure is pre-renal acute kidney injury.
Okay, what does pre-renal mean in this context?
Pre-renal simply means the kidneys are failing not because the kidney tissue itself is diseased, but because there simply isn't enough fluid volume and blood pressure reaching them to keep them functioning.
Ah, so the pipe's running dry.
Exactly. If aggressive fluid replacement isn't initiated, The kidneys simply shut down to conserve what little blood is left for the brain and the heart.
And the liver isn't doing any better from what I'm reading. We see multifocal hepatic necrosis, meaning areas of the liver are literally dying off from the viral attack.
Yeah, the liver gets hit incredibly hard.
But here's the part that really made me pause.
Yeah.
So what does this all mean when the guidelines state that rhabdomyolysis occurs in greater than 50% of cases? Like, why is a gastrointestinal virus causing massive, widespread muscle breakdown?
Well, it's a cascade of total systemic distress. The virus itself is attacking tissues, the immune response is causing massive inflammation, and the sheer lack of oxygen reaching the muscles due to that fluid volume collapse all combine to stress the skeletal muscles to the breaking point.
So they just give out.
Yeah, they undergo necrosis, they break down and die, and when muscle cells burst, they release an enzyme called creatine kinase into the bloodstream.
Okay.
The clinical guidelines highlight this because the sheer volume of elevated creatine kinase floating in the blood is an independent predictor of mortality.
Oh, really?
Yeah, it acts as a dashboard indicator, basically telling the clinician exactly how much systemic destruction is happening beneath the surface.
That is intense. Having established just how devastating this internal chaos is, we have to look at how doctors actually figure out what they are dealing with in the field.
Yeah, it's not straightforward at all.
Let's talk about the differential diagnosis. Because imagine you're a doctor in a triage tent in sub-Saharan Africa. A patient walks in with 103-degree fever, muscle pain, and crushing fatigue. You can't just assume it's Ebola.
Right, you absolutely can.
It's a massive intellectual puzzle.
It really is. Depending on whether there's a known active outbreak, Ebola is often not even the most likely possibility. The clinician has to act like a detective, ruling out suspects.
Okay, what are the main clues they're looking for?
The primary distinguishing features of Ebola disease are that rapid progressive systemic decline and the massive GI volume loss we talked about, which is then officially confirmed by an RT-PCR blood test.
Right.
But while you wait for that test, you have to look at the alternatives.
And looking at slide 7, the first alternative suspect is malaria. And the data point here is striking, actually. In one cohort of returning travelers, malaria was the correct alternative diagnosis 40% of the time.
Yeah, it's incredibly common.
The doctors solved that piece of the puzzle by hunting for parasites in a microscopic blood smear or using a rapid antigen test. If they find the parasite, the picture changes entirely.
Exactly. Another major suspect is typhoid fever. Clinicians distinguish this by its insidious or gradual onset compared to Ebola's abrupt crash.
Oh, that makes sense.
Typhoid presents with predominant abdominal pain and, crucially, relative bradycardia, which means the patient's heart rate is strangely slow considering how high their fever is.
That's a huge tell. There's also Lassa fever to consider here. It's another viral hemorrhagic fever, but the clues point in a different direction.
Right.
It has a more gradual onset, potential deafness as a lasting symptom, and its origin story is different. It's linked to exposure to aerosolized rodent droppings, not bats or apes.
Finally, the clinician must rule out severe influenza and measles. The key differentiator there is the respiratory system.
Because they cause coughing and sneezing.
It's exactly. Flu and measles present with marked respiratory symptoms, like a runny nose or a prominent non-productive cough. The clinical guidelines explicitly state that these heavy respiratory signs are typically absent in Ebola disease.
Okay, so the detective work is done. The RT-PCR test comes back positive. It is Ebola disease. The focus instantly shifts to acute survival.
Yes, immediately.
Hey there, sorry for jumping in. Before we move on, let's quickly compare the two major diagnostic approaches for Ebola. RT-PCR remains the gold standard because it directly detects viral RNA in blood, and it usually becomes reliably positive about 3 days after symptom onset. That's why a negative RT-PCR obtained after 72 hours is considered strong evidence against Ebola infection. Rapid antigen tests are faster and easier to deploy in the field, especially where laboratory infrastructure is limited. But they are less sensitive, so results, whether positive or negative, should always be confirmed with RT-PCR. One final high-yield point, blood is the preferred specimen. Saliva testing performs very poorly in living patients and is mainly reserved for post-mortem testing.
The foundation of modern intervention, according to slide 8, is optimized supportive care. This means aggressive, early intravenous fluid resuscitation and proactive electrolyte repletion.
Which is critical.
Right, pumping back in all that lost potassium, magnesium, and calcium to prevent hypovolemic shock and those fatal cardiac arrhythmias. But as I read the complication monitoring section for these interventions, I have to push back a little.
Well,
Wait, you have to pump them full of fluids to save them, but doing so creates a massive, life-threatening new risk.
yeah, that is the ultimate clinical tightrope right there.
Yeah.
You are trying to rapidly replace 10 liters of lost fluid, pouring it into veins that are already leaky and damaged from the systemic viral inflammation.
That sounds incredibly dangerous.
It is. The data shows that nearly 1/3 of heavily resuscitated patients risk hypoventilation and profound hypoxia.
Because you push the fluids too fast, the fluid backs up and floods the lungs, right? Pulmonary edema.
Exactly.
The patient literally starts drowning from the inside, and their already exhausted respiratory muscles just give out.
It is incredibly perilous.
Yeah.
It's not just about hooking up an IV and walking away. It requires careful, continuous, highly monitored titration of fluids.
Constant vigilance.
Yes. But thankfully, modern medicine now offers more than just fluid replacement. We have targeted therapeutics now. Monoclonal antibodies, specifically ensuvimab and inmazeb.
Oh, wow.
Yeah, these were proven in the pollen clinical trials to dramatically improve survival rates. They work by directly binding to the virus and stopping it from entering human cells.
And on the prevention side, we finally have a shield, the Ervebo vaccine.
A huge breakthrough.
It provides robust protection and is highly effective when used in a ring vaccination strategy. You vaccinate the direct contacts of the infected person and then the contacts of those contacts. You basically build a literal protective ring of immunity around the virus, starving it of any new human hosts.
It is a triumph of modern epidemiology.
Yeah.
But this is where the narrative takes another unexpected turn.
Okay.
Let's say we've navigated the acute phase. The viral storm breaks, the patient survives. The guidelines completely reframe what it actually means to recover, moving us from acute survival to the lingering, hidden dangers of the virus.
Okay, here's where it gets really interesting, because the clinical data introduces this concept of immune-privileged sites.
Yes, this is fascinating.
I look at this like a locked biological bunker. The virus realizes it's losing the war in the bloodstream against the monoclonal antibodies in the body's immune system, so it retreats.
Exactly.
It hides out in these highly secured bunkers in the body where the immune system's police force, the white blood cells, just aren't allowed to patrol as aggressively.
That locked bunker analogy is absolutely spot on. Human biology maintains these immune-privileged sites to prevent our own immune system from causing collateral inflammation and damage to our most highly sensitive tissues.
Which makes sense evolutionarily.
Right. But the virus exploits this evolutionary design.
Yeah.
Even after a patient achieves systemic clinical recovery and their blood tests completely negative, the virus isn't necessarily gone.
That is so creepy.
The guidelines detail 3 main sanctuary sites on slide 9. First, the central nervous system. The virus can quietly persist in the cerebrospinal fluid.
And the consequence of that is just terrifying. The data shows it can cause delayed relapse meningoencephalitis up to 10 months post-recovery.
Yeah, almost a year later.
You think you've beaten the disease, you are living your life, and nearly a year later, the virus emerges from the bunker and attacks your brain.
The second sanctuary site is the eyes, specifically the uveal tract. The virus persists in the aqueous fluid, triggering blurry vision, extreme sensitivity to light, and severe uveitis, which is inflammation of the eye.
Oh, that sounds awful.
It gets worse. What's particularly alarming is that the incidence of this uveitis doesn't fade over time. It actually increases over the first 2 years of survivorship. It's a progressive, lingering threat to their vision long after they leave the hospital.
Wow. And the third site on the anatomical map, the testes. The virus persists in seminal fluid, and the data here is just sobering.
It really is.
It enables documented sexual transmission of the virus up to 15 months after clinical recovery. A survivor, feeling perfectly healthy, could unknowingly trigger a brand new outbreak cluster more than a year after their blood tested clean.
Which necessitates an entirely new, holistic approach to public health. The protocol for post-recovery is a strict 3-step program on slide 10.
Okay, what's step 1?
Step 1 is clinical discharge and de-isolation. The World Health Organization dictates that no continued physical isolation is needed once the blood tests negative. The patient is no longer a casual contact risk. They can go home. They can hug their families.
Okay, but step 2 addresses that bunker in the testes, right? The semen testing program. Because of that 15-month persistence risk, male survivors require mandatory counseling regarding sexual transmission. The protocol mandates monthly semen testing until 2 consecutive negative results are achieved.
Right. And if they live in an area where that testing infrastructure is unavailable, it requires strict adherence to safer sex practices, specifically condom use, for a minimum of 12 months.
Wow. And then step 3 is comprehensive follow-up care. We can no longer just discharge patients and wish them luck.
Absolutely not.
We must establish dedicated survivor clinics. They need ophthalmologists to manage the progressive uveitis, neurologists to monitor for CNS relapse, and crucially, they need psychological support and community anti-stigma mobilization.
That anti-stigma work is just so important. I mean, these survivors fought a horrifying battle, and often they face terrible isolation and fear when they return to their villages. People are still terrified of them.
Which is heartbreaking.
It is. If we connect this to the bigger picture, the final slide summarizes the entire evolution of our understanding by contrasting the historical view with the modern reality.
Let's talk about that. The historical view was the acute death sentence. We viewed this pathogen exclusively as an uncontrollable, untreatable hemorrhagic monster with a near 90% fatality rate.
Yeah, it was seen as completely hopeless.
The medical response was largely limited to palliative containment. Lock down the area, provide comfort, and wait for it to burn out.
But the modern reality is a complete paradigm shift. It is now defined as a manageable, acute, complex chronic condition. With early identification, massive volume repletion of those 10 liters of lost fluid, and targeted monoclonal antibodies, the acute phase is highly survivable.
But surviving the acute viral storm is just the first hurdle, right? The new frontier is managing long Ebola.
Hey there. Sorry for jumping in again. Surviving Ebola does not always mean full recovery. Many patients go on to develop what's now called post-Ebola syndrome, or what some describe as long Ebola. Physically, survivors can experience severe joint and muscle pain, profound fatigue, hair loss, and difficulty regaining weight. Neurologically, some develop tinnitus, hearing loss, insomnia, memory problems, and cognitive slowing. But the burden is not only medical. The psychological and social consequences can be devastating. Depression, anxiety, PTSD, stigma, even loss of employment and social isolation years after recovery. So when we talk about Ebola, we're not just talking about an acute viral illness. For many survivors, the impact continues long after the infection itself has resolved.
We have to manage this complex web of viral persistence, those locked bunker sanctuary sites, and profound convalescent morbidity.
Right. And the defining statement of these guidelines changes everything we thought we knew about outbreak management. The definition of outbreak control has permanently expanded. It no longer ends when the last patient tests negative in the blood. It ends when the survivor population is fully clinically and socially rehabilitated.
That is a massive, incredibly challenging shift in responsibility for the global health community. We've walked through this entire update today, from that initial zoonotic spillover from a bat in the forest, through the 10-liter fluid collapse in the triage tent, the detective work of differential diagnosis, and all the way to the long-term reality of immune sanctuaries.
It's a lot to take in.
It is. Understanding this disease not as a movie monster that bleeds you out, but as a condition of massive fluid loss and complex chronic persistence, it completely changes how we fight it.
It does. And this raises an important question for you to consider as we look to the future. Building on this concept of long Ebola and these immune-privileged sanctuaries, how does this redefine the concept of cured for other severe viruses in our modern era?
Well, that's a great question.
Right. If a pathogen can hide in the fluid of your eye or deep within your nervous system for years after the acute infection is over, well, perhaps the medical story of any pandemic is really only just beginning the day the blood tests come back clean.
That is a deeply sobering thought, and one that will definitely linger as we rethink what recovery really means. Thank you for joining us today as we navigated the clinical realities behind the terrifying headlines. Keep questioning the paradigms, keep exploring the data, and we'll see you on the next deep dive.
This content is not intended for clinical guidance, use in medical clinics, or patient management. It serves as supplementary information for medical students preparing for examinations and should be used in conjunction with their official course materials. In the event of any discrepancies between this content and the prescribed curriculum, the curriculum shall take precedence until further review and clarification are made by the concerned students. The contributors to this video have exercised due diligence, but the content may become outdated quickly.